Welcome to This Explainer. Today, we're navigating what is arguably one of the most high-stakes puzzles you'll ever face in the emergency department, evaluating abdominal pain in a pregnant patient. I mean, you're literally caring for two patients at once, the normal anatomy is completely distorted, and honestly, the stakes just couldn't be higher. So let's start with the critical question that drives all our clinical anxiety in these cases. How exactly do normal pregnancy adaptations hide serious, life-threatening pathology? Well, think about it. The growing uterus physically displaces organs. The immune system naturally shifts. And those classic peritoneal signs we rely on, they get completely dampened because the abdominal wall is stretched out. It's a perfect physiological storm that can easily mislead even the most experienced emergency physician. Here's the clinical pathway we'll be breaking down today. 1. Initial assessment. 2. Differential diagnoses. 3. Laboratory pitfalls. 4. Guideline-directed imaging. 5. Safe analgesia. And 6. Key takeaways. All right, Section 1. Initial assessment and history. Navigating the fog. Right off the bat, your initial history has to aggressively target the red flags. We're talking vaginal bleeding, fever, altered bowel habits, urinary symptoms, and reduced fetal movement. But here is the kicker. Your standard pain localization is totally unreliable here. Remember how we said organs get displaced? The appendix actually migrates upward. So what presents as classic first trimester right lower quadrant pain might actually be right upper quadrant pain by the time they hit the third trimester. Moving on to Section 2. Key differential diagnoses. Splitting the board. The literal second you walk into that room, your diagnostic mindset has to split in two. On one hand, you are actively ruling out obstetric and gynecologic crises, things like an ectopic pregnancy early on, or maybe placental abruption and uterine rupture later in the pregnancy. But simultaneously, you're evaluating for traditional surgical emergencies, like acute appendicitis, cholecystitis, or a bowel obstruction. Pregnancy absolutely does not grant immunity to standard surgical pathologies. Because the anatomy is so distorted, mapping these massive differentials directly to specific abdominal quadrants really gives us a fighting chance during the physical exam. For example, right flank pain might signal renal calculi or pyelonephritis, sure, but you absolutely cannot cross appendicitis off your list just based on location alone. We have to systematically rule out those life threats region by region. That brings us to Section 3, Laboratory Evaluation Pitfalls, the shifting baseline. You need to be hyper-aware of physiologic leukocytosis. While a non-pregnant normal white blood cell count caps at around 11,000, a pregnant patient's baseline can safely sit all the way up at 15,000. And it gets crazier. It can spike to a massive 25,000 per microliter during labor, completely normally. So a high white count alone is absolutely not an automatic trigger for the OR. Let's be really clear about this pitfall. Physiologic leukocytosis is a totally normal, non-infectious increase that perfectly mimics infection. Because of this, you really have to look for other clues. You need to rely heavily on the wider clinical picture. Look for a left shift or check inflammatory markers like CRP, rather than just reflexively reacting to an isolated high WBC. Next up is Section 4, Guideline-Directed Imaging, the definitive sequence. According to the latest IDSA and clinical guidelines, there's a very rigid path you need to follow here. Step 1. Always start with ultrasound. It's safe and it's readily available. Step 2. If the ultrasound is inconclusive, you move to an MRI without gadolinium. And Step 3. You strictly reserve CT scans for severe, life-threatening scenarios where MRI just isn't an option. Think major trauma or severe sepsis. This scan perfectly demonstrates that second-line modality at work. What we're looking at is a T2 sequence, clearly identifying a large degenerating fibroid, all without exposing the fetus to a drop of ionizing radiation. Red degeneration is excruciatingly painful, and MRI gives you those high-fidelity answers when your initial ultrasound is indeterminate. The IDSA guideline data completely backs this up. It shows highly accurate sensitivities when ultrasound provides definitive results. But let's be real, a huge proportion of ultrasounds in pregnant patients end up being indeterminate. When that happens, this data proves that using MRI as your backup provides excellent diagnostic accuracy, taking the guesswork out of whether or not your patient needs to go to the operating room. Moving on to Section 5, Safe Analgesia Administration, Dispelling the Myths. Take a close look at this principle, because it is a vital medical, legal, and clinical point. You must treat the patient's severe acute pain. There's this old, lingering dogma that giving pain medication will mask a surgical abdomen. That is entirely false. Providing adequate analgesia actually relaxes the patient and facilitates, rather than hinders, a thorough and accurate physical exam. The guidelines on this are super straightforward. First line is paracetamol, but please do not hesitate to use short-term opioids like morphine or fentanyl for severe pain. If you have a patient writhing in agony from a possible appendicitis or a ureteric stone, treat their pain. Just adhere to the golden rule of toxicology. Use the lowest effective dose for the shortest duration necessary. Finally, Section 6, Summary and Key Messages. The mental checklist. I want you to keep this mental checklist in your back pocket for every shift. First, maternal resuscitation is always paramount. A stable mother is quite literally the best environment for the fetus. Second, anticipate those physiological lab shifts, like that bumped up white count. Third, rigidly follow the ultrasound to MRI sequence to protect the fetus from radiation. And fourth, treat pain aggressively so you can actually examine the patient properly. As you head into your next shift, remember that the pregnant abdomen is a master of disguise. So here's my question for you. The next time a 28-week pregnant patient rolls in with isolated right upper quadrant pain and a white count of 14,000, will you immediately anchor on the gallbladder, or will you remember the wandering appendix? Thanks for joining me on this explainer, and stay sharp out there.